You're listening to the Sick and Good podcast. My name is Dustin Messick. I'm a registered dietitian nutritionist and a cancer survivor.
My name is Colin Goodwin. I'm a clinical psychologist and a cancer survivor.
In 2024, we are highlighting the Cancer Awareness Months in a special series.
We're promoting wellness by having discussions on screening, treatment, and recovery throughout the cancer journey.
To find a balance between sick and good.
That during the cancer process, both can be true.
The Sick and Good podcast is for educational purposes only. The podcast is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Always seek the advice of your physician or other qualified healthcare provider with any questions you may have regarding a medical condition or treatment, and before undertaking a new healthcare regimen.
Now, February is Gallbladder and Bile Duct Cancer Awareness Month. And to speak to this awareness, our special guest is Dr. Juan Valle. Dr. Valle is the current medical director of the Cholangiocarcinoma Foundation and was most recently served as a professor and honorary consultant in medical oncology at the University of Manchester and the Christie NHS Foundation Trust in Manchester, England. Dr. Valle was part of the team establishing the first standard of care for patients with advanced cholangiocarcinoma in 2009 and is a founding member of the International Biliary Tract Cancer Consortium. His research focused on developing new therapies for pancreatic, biliary, and neuroendocrine cancers, and he has been instrumental in designing and developing many clinical trials. Speaking on his research a little further, he has set the standard for patient care in cholangiocarcinoma. I just wanted to welcome you to the conversation, Dr. Valle.
Thank you very much for the welcome. It's a pleasure to be here.
I want to have you maybe just define cholangiocarcinoma.
Yes, so cholangiocarcinoma, unfortunately, is a bit of a mouthful. It really refers to cancer of the bile ducts. And just to orientate you, I want you to think of a tree trunk and the roots of the tree. Effectively, this is what we have going into the liver. So all the bile that's produced by the liver comes out through the tiny little roots into bigger and bigger branches out into a trunk that then comes out of the liver and then delivers the bile to the small bowel so that helps to aid digestion. And coming off the main trunk, you also have the gallbladder, and that allows the body to collect bile, but only to release it when people are eating. So you get small contractions of the gallbladder, releasing the bile to then mix and digest the food. And cancers can develop anywhere along that system. So either the bile ducts inside the liver, or the gallbladder, or the main trunk as it comes out of the liver, anywhere down to the small bowel. And we call the cancers arising from the bile ducts cholangiocarcinoma.
And can you tell us about the screening process for bile duct cancer?
Yeah, good question. The problem is that this is a very rare cancer. There are between 8 and 10,000 new cases in the US a year. So it's not possible to do a screening program as we know it for cancer, much like we would for lung cancer, breast cancer, bowel or colorectal cancer, prostate cancer. So currently in the wider population, there is no established screening program. But we do know that cholangiocarcinoma is more likely if people have a condition called primary sclerosing cholangitis. That again is a mouthful. We call it PSC for short. And this is, it's a process of long-standing inflammation in the bile ducts. It's predominantly an immune process. And what happens when you have a very prolonged period of inflammation is that increases the risk of a cancer developing. So we do know that in those patients, there is a screening program, and these patients are often very closely monitored. And that includes things like imaging with MRI scans, magnetic resonance imaging scans, as well as blood tests. But currently, for a wider population, there isn't any established screening process.
In addition to individuals who have PSC, are there any particular populations that this affects?
So that varies quite widely across the world. So I've said that this is a rare cancer in the US and in the West general, it is a rare cancer. It is much more common, more than 20 times more common in places like Northeast Thailand. So in Northeast Thailand, the main problem they have is a liver fluke. So this is a parasitic infection. And what happens is that people eat, we call it raw fish, but it's more like a tartar fish. The fish is raw, but it's kind of ground up together with spices and coriander and other herbs, but it's eaten raw. And unfortunately, the parasite is ingested as part of that process. It then lives in the bile ducts, causing that same chronic inflammation over many decades. And that's why cholangiocarcinoma is very prevalent in that part of Northeast Thailand and along the Mekong River. In the West, however, PSC is the most notable population that is at risk. But we also know that there are some other risk factors, and these again tend to be linked with chronic inflammation. So, for example, patients who have hepatitis, so hepatitis B and C, long-standing, we know that increases the risk of cholangiocarcinoma. And we also know now that diabetes and obesity are risk factors. And I think this is one of the reasons why we have a concern that cases of cholangiocarcinoma are increasing in the US rather than decreasing.
It does sound like there is that inflammatory, perhaps cause, or at least that risk factor.
Yeah, and just to quickly add, we know that patients who have inflammatory bowel conditions like ulcerative colitis and Crohn's disease, these are patients who, again, are more likely to develop PSC and consequently cholangiocarcinoma. So that really does speak to this being an inflammatory condition in the background, which needs to be present for a prolonged period of time, often many years, before the cholangiocarcinoma develops.
You had mentioned that this is a very rare form of cancer. We wanted to ask what the current prevalence rate is.
Yeah, so as I mentioned, it's 8 to 10,000 new cases a year. And unfortunately, the prevalence is very similar. And I think this speaks to a cancer which has a poor prognosis, often diagnosed late, in that the incidence and the prevalence rates are very similar.
What are the current treatment options for this cancer?
So I think, like with any cancer, early diagnosis is important. And in people who can be diagnosed early, which is about 15% of all the patients, then they're able to undergo surgery. And surgery offers the chance of long-term cure. The nature of surgery will really depend on where the cancer has started. So remember, in the image that I gave you, the mental image that I gave you, if the cancer starts in the root system, deep inside the liver, then surgery would mean removing part of the liver. If the cholangiocarcinoma arises in the trunk, especially down at the lower end, where it feeds into the small bowel, then the surgery is quite different. Often the liver isn't removed. The surgery involves removing the lower end of the bile duct and part of the pancreas because it runs next to the pancreas. So the technical details will vary depending on where the cancer starts, but surgery offers a chance of long-term cure, followed by a 6-month course of chemotherapy. That chemotherapy is an oral chemotherapy, a tablet chemotherapy called capecitabine. Sometimes patients may receive more intense chemotherapy combinations. Currently, those are undergoing evaluation in clinical trials, but the standard at the moment would be considered to be the tablet capecitabine chemotherapy for 6 months. But the challenge is most patients, that's the other 85%, are diagnosed with the cholangiocarcinoma at an advanced stage. That means that it's not possible to do an operation to remove it, so it could be locally advanced, or indeed it may have spread to involve other parts of the body. Sometimes it's the lymph glands, which are the body's dustbin system to try and clear away cancer cells, but it can go beyond to other places like the lungs, the lining of the abdomen, and other places like that. For those patients, then treatment is often aimed at controlling the cancer rather than curing it, as we were planning with surgery and adjuvant chemotherapy. So for patients with advanced disease, the current pillars of our treatment will include chemotherapy, more recently immunotherapy, and targeted therapies for specific subgroups. And I'm very happy to go through all of those in a little bit more detail.
I'd love to hear about what are some of the common effects of those treatments and what that really looks like.
Yeah, so maybe we focus on chemotherapy first. I think people have a very good preconception of what chemotherapy can cause in terms of side effects. The standard chemotherapy that most patients would start with is a combination of cisplatin and gemcitabine. On the whole, the chemotherapy is reasonably well tolerated. Patients are not expected to lose their hair. Sickness is something that can be controlled ahead of time, and it may cause low blood counts, by which I mean some patients get anemic, some people bruise more easily if the platelets are low, and it also increases the risk of infection when the white cells are reduced. Other non-specific side effects of chemotherapy include tiredness, fatigue, and sometimes patients can get pins and needles or a neuropathy affecting their fingers and toes. There are other chemotherapy combinations, and they'll have variations on a theme of those side effects. Some will cause hair loss, but that really depends on which particular combination is being used. One of the more recent treatments that we're now using is immunotherapy. This is treatment called durvalumab on the back of a trial called the TOPAZ study that's currently approved for use in patients with advanced cholangiocarcinoma. And there is another clinical trial called Keynote 966, which has reported the benefit for another immunotherapy drug called pembrolizumab. And pembrolizumab and durvalumab are very similar in terms of how they work. And in fact, looking across the two clinical trials, the magnitude of additional benefit over and above chemotherapy, because they're given in combination with the chemotherapy, was very similar. And the side effects of immunotherapy tend to be very different to those of chemotherapy. The main side effect will be loose bowels or even diarrhea. Some patients can get a rash, and it can trigger the own body's immune system to get a reaction against the normal tissues. So that can sometimes cause abnormality in a blood test like the liver tests, or more commonly the thyroid gland. So these are side effects that clinicians are very aware of, and they'll be monitoring while patients are receiving treatment. And the final pillar is targeted therapy. Just to quickly delve into that in a little bit more detail, we now know that cholangiocarcinoma is one rather complicated word, but in fact, it covers lots of different subgroups of biliary tract cancer that may have a molecular alteration that's driving that cancer. Now, in order to know which molecular alteration is causing the cancer, patients will need to have the tumor sent for biomarker testing. And that will allow us to look at the DNA, the RNA of the tumor to understand what is driving their particular cancer. And we now have a number of treatments which are specific for certain subgroups. And these will include, for example, patients with an IDH1 mutation or an FGFR2 fusion, and tumors that have got HER2 amplification. There are others, MSI high, TMB high. So you can see it's now getting a little bit complex. But I think the important thing is that clinicians are aware of and test for some of these rarer subgroups, because increasingly there are new therapies that are available specifically for targeting those subgroups. And each of those will have their own side effects, which I won't go into just because they are so varied, and we're now going down very small groups of patients.
Thank you for that. It's very detailed response. Was there any common effects related to the surgeries that you mentioned as a part of the treatment process?
Yeah, good question. So the surgery to the liver, the liver, as you know, has got a lot of overcapacity. And so you can remove up to 70% of the liver. People often say the liver regrows. And just to quickly say that you don't sprout a new liver, or the liver doesn't, grow back the bit that you've removed. What happens is that the liver that is remaining after the surgery just gradually enlarges to take up the capacity of the work it needs to do. So it won't go back to the completely normal size, but it will enlarge enough to be able to then deliver its function. Now, patients don't normally notice that in terms of any symptoms. So from liver surgery, the main problems, of course, are to have recovery from a large abdominal wound with any pain and risk of infections, risk of bleeding, all the things that you would expect from a major operation. The surgery that involves the head of the pancreas is often called a Whipple's procedure. And a Whipple's procedure is a little more complex in that it requires not just removal of the tumor, the surrounding tissues, but everything has to be replumbed again afterwards to make sure that the bile is still draining, that the pancreas is still draining, that the stomach is still draining, and it allows the people to still digest their food normally. That often means that patients will need to have additional pancreatic enzymes, because most of the enzymes are produced in the head of the pancreas. And if that's removed, then sometimes patients don't produce enough of their own enzymes, and they have a problem, particularly digesting fat or protein. So they will have abdominal pain, a lot of abdominal gas or wind, some indigestion, and offensive smelling stools, which can, if severe, be quite pale and greasy. And that just means that the body has been unable to digest the fat that somebody has eaten. And that can be dealt with by topping up with pancreatic enzymes, which often then is something that patients need to be on for a prolonged period of time, or even for life.
Well, modern medicine has come a long way. Are there any recommended lifestyle changes for those diagnosed?
I think not specifically is the short answer. I think the main advice would be for people to remain active, take enough exercise, have a good balanced diet. And I think the important thing here is that there's no one food that will make things particularly worse or miraculously better. So while your patients are on chemotherapy, there are sometimes some advice about eating things that may contain, for example, a live bacteria, just because the body's immune system has been lowered. But other than that, the recommendation would be to just keep active, have a fairly rounded diet. And my personal advice to people is not to go too fatty. You don't need to go into any fatty diets, cutting out extreme foods or going to any particular diets that might enrich for certain nutrients and things like that. I think we all want to make sure that we've got to do as much as we can to help ourselves. But I think we also need to be grounded in as much sound evidence as we can.
That's a very good answer. As a dietitian, I feel like a lot of my recommendations are just like eat a balanced diet and do a little bit of exercise.
Yeah, absolutely.
And there's no one food. As a cancer survivor, I've heard all of the claims, like eat this and it's going to cure your cancer.
Yeah, and I think it probably also comes from a place where people are very well-meaning and they're trying to help with advice. And there's a lot of stuff out there on the internet that you can find, and you can convince yourself that any one food or any one supplement is a miracle. But the reality is that our bodies are very good at correcting. So if you have too much of one thing, our physiology allows us to correct and get rid of that and excrete it. It will correct our body's acidity, our pH, and so on. So I think we need to base as much as we can on good evidence.
And speaking of that, I did want to ask some questions about your research, but I also wanted to just share that as I was listening to you talk about the current immunotherapies and the targeted therapies for cholangiocarcinoma, and hearing those markers, I almost had to envision like a chessboard, talking about these like these markers of like, okay, move this piece to this spot on the board. But I just wanted to share that and wanted to ask if you could just speak to some of the research that you've done and some of the clinical trials that you've been part of.
Yes, I'll quickly speak to your chessboard. I think you're right. It is about strategy. And just before I talk about the research, I think one of the important things about managing patients with cholangiocarcinoma is to be part of a multidisciplinary team, an MDT. And what we do as part of that MDT is to try and work out the strategy for how we're going to manage individual patients. What's the first treatment? What's the next treatment? Are there any options based on biomarker testing so that we can line those up? And then we're trying to work out, are these treatments available? Do we need to consider a clinical trial to access new treatments? Is there a new biomarker that we don't know that might be a treatment, but there might be a trial? So I think your analogy of a chessboard is very appropriate in that it is about strategy for best managing patients. So let me quickly tell you about the research that we've been doing over the past, really 20 plus years. Just a little bit of insight. When I was originally appointed to staff 23 years ago, I was appointed to treat patients with bowel cancer, colorectal cancer, not in fact biliary tract cancer. And that was around the time when we were developing multidisciplinary teams and we were discussing patients with bowel cancer who had disease in the liver and how that might be dealt with. And occasionally there would be patients presented with cholangiocarcinoma. And at that time, there was no standard treatment. So there was no standard chemotherapy. There was no standard radiotherapy. Surgery was used for selected patients. And when I was looking into the literature at that time, one of the common themes of the papers was this cancer is too rare. And I often saw that as an excuse for not doing the research. And I think what we then felt across the UK was that what was missing was not the patients, it was a collaboration. And we set up, with the help of Cancer Research UK, we set up some national trials that were specifically aimed at answering the basic questions. We really had to go back to the foundations. Breast cancer, bowel cancer, lung cancer were so far ahead, and they had many treatment options. They'd established what the standards of care were. We were really having to start from ground zero. And the very first trial that established a standard of care was the ABCO2 trial. ABC stands for Advanced Biliary Cancer. And the ABCO2 study was really quite a simple study comparing two drugs versus one. And we were able to show that combination chemotherapy improved survival. It wasn't magic. It wasn't suddenly buying patients a long period of time, but we were able to put that first foundation stone in place against which new treatments and new trials could be tested. And that combination of chemotherapy, which we presented in 2009 and published a year later, stood the test of time for the last 12 years or 10 years before new treatments were shown to improve things a bit better with the addition of immunotherapy. In addition to that first study for patients with advanced disease, we also ran the Bile study, which was the adjuvant study for this was patients who had undergone surgery, and they were either allocated to normal standard follow-up, which wasn't any further treatment after the operation, or to have the 6-month course of tablet chemotherapy, the capecitabine. And we know that because patients receiving the capecitabine lived longer after surgery, then that became the next standard of care. So again, we have a second foundation stone in place for patients after surgery. And the other foundation stone we were able to put in place was what happens after you've had your first tranche of chemotherapy and the cancer then gets worse and needs a further treatment. I mean, in fact, many clinicians were already using chemotherapy, but there was no real evidence to tell us how much benefit that was. And so our next study was the ABC06 study, which showed that giving some additional chemotherapy with a combination of 2 drugs called 5-FU and oxaliplatin, or FOLFOX for short, did improve survival, although only very modestly. And this allowed patients to have a more informed decision with their physicians, but it also highlighted the real unmet need that we have in cholangiocarcinoma to develop better treatments, understand the biology better, understand about these biomarker-driven subgroups, as well as looking to other pillars like immunotherapy to see if we could improve patient outcomes.
Thank you so much for sharing that important research that's been done. I think it's pretty incredible. I mean, like with this the ABC, is that right?
Yes. Yep.
Seems like a very simple study, but important to then have a larger group. If you're having, was that one of the international studies that had collected that data?
No, so that was in fact a UK only study. And one of the reasons that it was successful, so just to give you a little bit of context, the largest study that had been published in the literature prior to ABC02 was in the region of around 80, 85 patients. ABC02 was aiming to deliver a 410 patient study. So you could see that it was something that was quite ambitious in its time. And, but I felt the UK was a slightly Goldilocks situation in that the prevalence of patients with biliary tract cancer was enough to do this magnitude of a study if all the centers collaborated, and over 30 centers across the UK were registered to recruit patients to the study. So it really was a national initiative. If
that porridge was just right.
Yeah, exactly. So if it was much rarer, we wouldn't have been able to deliver it. If it was much more common, then it's likely that institutes would have competed. There have been competing studies, smaller numbers, and so on. So it really did hit that sweet spot.
I'm pretty impressed that your ABC02 trial had been cited 3,000 times. That must be like a milestone.
Yes. It has been cited, I think, in most of the papers that then talk about systemic treatments for biliary tract cancer, just because it has been that cornerstone. And I think I just need to pause here to acknowledge that without patients and then their caregivers willing to participate in clinical trials, we wouldn't be able to move the field forward. So it really is thanks to them for being willing to participate in the trials.
I was just thinking of with that many citations, at what point do you get something to hang on the wall? Like it's gone platinum, it's certified, right?
Yeah, I don't think that ever happens. I think as a clinical investigator, it's never enough. You kind of see that as a milestone, but then you want to move on. We want better outcomes for patients. We want more treatments, better treatments. But let me tell you one thing that we did see as a big difference. By the time that the ABC02 had started, not reported, but started, the frequent response from the pharmaceutical industry for any proposals to run a clinical trial in cholangiocarcinoma was that this is not in our development plan, or this is too rare, it's not feasible. we're now in an amazing position where we have many industry partners who are running industry-sponsored clinical trials, but are also opening up their treatments for investigator-led studies, academic studies. So we're now a much better position where we have that engagement, not just with patients, but into industry and also with the regulators, because obviously they're in a position to be able to approve some of these treatments for patients. And we have a slightly different regulatory environment across the world. I've obviously dealt very much with the UK system for many years, but the FDA has approved many new treatments, particularly over the last couple of years for patients with cholangiocarcinoma.
It's fantastic. I was just thinking, and this is just probably how my pop culture brain works, is like thinking of the drug names specifically for like the immunotherapies. I thought, like, are they naming drugs or are they Star Wars characters? Like,
so it's not quite as random as it appears. Remember that every drug has got two names, so it's got a generic name as well as a trade name. But in fact, everything that is a monoclonal antibody will end in mab. So, durvalumab, pembrolizumab, you can tell just by the name that they're monoclonal antibodies. And anything that's a small molecule, we call them tyrosine kinase inhibitors. They're often tablets, are NIBs at the end. So we've got ivosidenib, pemigatinib, infigratinib, futibatinib. They're all NIBs at the end. So often the clue is in the name if you just know how to read the clues.
I'm so glad I made that comment.
Yeah, I
did not know that.
Yeah. What's going on with cisplatin? What's that name about?
So that's actually, it's just a chemical name because it is actually platinum. And in the chemical, when you're describing the chemistry of platinum, you can either be in the cis form or the trans form. This depends on how the platinum molecules are arranged. It just happens to be in the cis form, which is why it's called cisplatin. And just an interesting story around cisplatin. The reason it was found to inhibit cancer cells was because accidentally some platinum electrodes were left in a plate, and it was seen that cells did not survive in between the two electrodes, and hence platinum eventually became acknowledged as a treatment for cancer. So sometimes these are serendipitous findings.
So it's like an accident, like penicillin.
Indeed.
Or the Doritos.
Or Doritos.
Well, I wanted to thank you so much for being a part of the episode. I guess before we wrap up, I wanted to ask if there was anything else that you would like to add, specifically in acknowledgement of Gallbladder and Bile Duct Cancer Awareness Month.
Yeah, so I think the one thing we haven't talked about is the foundation, for whom I am now the honor of being the Chief Medical Officer. Cholangiocarcinoma Foundation has been there to support patients in terms of advocacy and education and support, but it has also been supporting research and facilitates an annual meeting to get. It's a very unusual meeting in that we have a mixture of basic scientists, we have clinicians, we have investigators, but also patients and caregivers. And at this meeting, for example, you'll have a complex question or a complex scientific concept being explained, and patients will ask in an open forum, what does this mean for me? And it really helps to ground you to why we're doing these things. And it's a foundation that has also allowed us not only to engage with patients and caregivers, but also with industry partners, with investigators internationally, but also with regulators. And so it's very well placed to be able to further the benefits for patients with cholangiocarcinoma, both in the US and abroad.
Well, again, thank you so much for joining us, Dr. Valle. I enjoyed hearing the research that you've done and just hearing more about the bile duct cancers for today. So thank you so much.
You're very welcome.
Our podcast will discuss topics related to cancer treatment and the recovery process, including diagnosis, family support, resources, medications, and nutrition. We aspire to have conversations pertinent and relevant to the cancer journey. Thank you for listening to the Sick and Good podcast. We'd like to invite you to connect with us on our social media at Instagram and Facebook accounts. We're also happy to share that we have launched the Sick and Good podcast website, sickandgood.com. This website is a place to read our bios, subscribe to the podcast, listen to full episodes, or read full transcripts, and contact us with your questions or comments. We care about your listener experience and would love to hear from you to keep the conversation going on the topics of cancer and wellness.